For those that don't know, my name is Stuart Schlossman. I'm president and founder of MS Views and News. I too have multiple sclerosis. That's how all of this began years ago. For those that don't know, this is an MS Views and News educational program. We lead currently the United States with all the other organizations and many other companies and communities in providing rural and underserved communities with information about multiple sclerosis. And the information is, it's resources, it's information about the medications, it's about the symptoms. You'll be hearing about a lot of this today. We have a lot of different supporters. We have EMD Serono and Sandoz and Biogen, Genentech, Banner Life Sciences, Novartis, Bristol-Myers, Squibb, and Sanofi. And the reason why we have all these supporters is because they want us to be able to get out and about in the United States and providing these programs in the areas that we are providing. Also today, at today's program, exhibiting, we had Alexion, Bristol-Myers Squibb, Banner Life Sciences, Janssen, and the National Multiple Sclerosis Society, which I'm very, very glad that they are here today as well. There's somebody that's here in the audience today and who did, excuse me, a great job helping me to promote today's program. And without him, we couldn't have done that. So I wanted to thank him for being here. Scott. This is Scott Benz, all right? And Scott went around to different physical therapy centers for us in the area. He went around to the different hospitals. He went trying to promote this program as best he could in various places. And no, I'm not going to cry. I'm losing my voice again, all right? And I wanted to thank Scott for doing this. And I'm not going to cry, but I am losing my voice. So Scott, thank you very much for doing this. I wanted to give you the recognition. I hope others in the area do so as well. And I need water. All right. Excuse me. Thank you, Scott. I worked with Dr. Calkwood I think it was about 5 years ago in Franklin, Tennessee, where he did a special project with MS Views and News and doctors Samuel Hunter and Dan Cantor. And the three of them got, they got a grilling from me in Dr. Hunter's office, as well as speaking about things that the MS community greatly needed. And I liked hearing him speak the way that he did so much that I said, I've got to have him speak. And then, of course, 2020 happened, and that didn't happen. So, but this year we wanted to have him. Next year we're going to have him. The following year we hope to have him at different programs. So I just wanted to let you all know that to his talk today, he's going to be speaking about visual disturbances with multiple sclerosis. He's going to speak about understanding new and emerging therapies, including biosimilars, and he will be speaking about shared decision-making, and I'm sure he'll find other things to speak to you all about as well. But I want to introduce Dr. Calkwood. He's a neurologist and he's a neuro-ophthalmologist. Makes him a very special doctor. He specializes in multiple sclerosis. He's the medical director of the Shapiro Center for MS, a comprehensive MS center in Minneapolis, Minnesota. Dr. Calkwood and his team at the Shapiro Center are nationally and internationally recognized. Dr. Calkwood has 35 years of experience treating MS patients and performing clinical research, so you'll hear a little bit about that as well. And if you have any questions about clinical research, this is the guy to ask. So let's welcome Dr. Jonathan Calkwood. Have a good one. Thank you. The clicker is up here.
Thank you, Stuart. It is a pleasure to be here. I'm actually a little humbled. Emily, I got chills. I mean, I just teared up at your presentation. OMG. That's me trying to be young. OMG, right? Some of those kids, I mean, they're kids. They're just kids. And you're right. We do not have an awareness of the impact, let alone the prevalence of MS in children. And again, I'm having a little trouble choking up just thinking about that. So thank you for what you do, and you're amazing. Kathleen, MS Society, I can't say enough about what the MS Society does. Kathleen was telling you about what they're doing in community, what they do for our patients day to day. The patients I see in the exam rooms, the things that my patients deal with, the things that the healthcare system just doesn't support, and then the MS Society is there. There are programs, I'm sure we could go on for hours, but they get in the lives of people. They get in the lives of persons with MS. We probably refer 5 or 6 people a week to some support service that the MS Society has, social support services. They'll send people to persons with MS, they'll send them to your home to evaluate like an OT and a PT to make sure your living situation is good. These are services we just can't get. They're financial support, the sort of things that the MS Society does. So anyway, shout out, huge shout out. So I could not take care of my patients the same way if it wasn't for the efforts of the people at the MS Society, Kathleen included. So thank you very much. So now I get to talk to you today about something I'm really passionate about, and well, a few things I'm really passionate about, and then some things that are, we're going to hit a few boring things when we talk about biosimilars and the FDA, but we'll get there, we'll get through that. And then I think the issues that people with MS face, and I think I'm going to focus a little bit on visual. First, I want to give you a little introduction. Shout out, obviously, a lot of supporters. None of this would be possible with all of them. US Views and News Stewart, thank you. Again, thank you for inviting me to speak today. All right, we already heard this. What is MS? Well, MS is different for everybody. MS, the impact of Emily's programs on children's lives, what you saw, the comments before and then the comments after. MS is complicated. I'm going to stick to the medical side. So, MS is a disease of the central nervous system. Central nervous system, brain, spinal cord, and optic nerves. No, pretty straightforward. If someone has a neuropathy, a peripheral neuropathy, many times people complain about symptoms like tingling and they'll call it neuropathy. That's actually not neuropathy. At least to a neurologist, because that's a peripheral nerve. But you can get those symptoms from the spinal cord, and they sound just like someone who has diabetes. So, and diabetics do get neuropathies. Myelopathy is damage to the spinal cord, brain, or optic nerves, and we'll talk about optic neuritis, and we'll talk about, at least we're going to focus more on the impact of MS on the visual system. So, a few things first. How does the brain work? So how do nerves work? So this is a schematic of a nerve cell, and we see, I love the demonstration of myelin that Emily put on. That is just perfect. Really describes this, really takes this home. These little sleeves, if you will, along the nerve allow fist bumps. I think I'm going to be explaining this in a whole new way to my patients now. I'm going to have to do the fist bump thing. So it's like the nerves have to fist bump to hand off to each other. And myelin accomplishes that. So myelin is very important. It's not the only thing. Here is what makes myelin. The little cell in the middle here. Do we have a pointer here? Little cell, the glob in the middle, there's two axons, two nerve cells on either side with their axons, and the glob in the middle is something called an oligodendrocyte. That is the cell that makes myelin. When we talk about recovery and remyelination, we talk about, there was a question earlier about improvement. How can we cure the disease? Not sure, but improvement. Myelin makes a big difference. Myelin grows back. Nerve cells do not. So if we have damaged myelin, but we still have an intact nerve cell, that nerve can recover, that nerve can heal. There's research ongoing now looking at how to promote and further develop myelination or remyelination after a nerve has been injured by MS. Now, this is a schematic of what a healthy nerve cell should look like within the central nervous system, essentially within the brain. Now, there's a few other cells here, but what you should notice is the absence of any immune cells. You see an intact cell body, the neuron, and you see an intact myelin sheath and a whole lot of other neurons connecting to each other in a normal, healthy brain. This is MS. Not to scale, obviously, but all of the additional players here, if I can go back, there, compared to here. So all of the additional players there do not belong. In a normal, healthy brain, you do not see T cells, macrophages, B cells. The little dots there are various antibodies and chemical messengers. So this is the veritable war that's going on in people's brains. Even if someone with MS is not experiencing new symptoms or not having a relapse, this is going on. Well, what happens? The end result of this nerve cell is it demyelinates. If it demyelinates enough, it gets to that third window, where if you look closely, the axon underneath the myelin is cut. Once that transection happens, that nerve cell is dead and gone forever. Oligocells, we can grow new ones. We have a certain amount of, you might loosely call them stem cells that will turn into oligocells and remyelinate naturally. So our bodies, our brains have the ability to do that. Unfortunately, if that nerve cell transects, it's gone. It's gone forever. By the age of 19 years old, 20, 21 maybe, we have made all the neurons we're going to grow. We continue to myelinate them so those neurons work better. That was comfort to me when my kids were teenagers and I knew, oh, they have all the brain cells they're gonna have, but they're not using them very well, right? Yeah, well, and they're myelinated. My kids are now in their mid to late 20s. They're getting fully myelinated now, and they're starting to make a little bit better decisions, and they're growing up, And so yeah, they're using those brain cells a bit better, and part of that's myelination and reinforcing pathways. But since they were 19 years old, they've been gradually losing brain cells. And we all are. And we can't grow them back. They're very, very precious. So what causes MS? I'm going to cut to the chase. We don't know. We don't know. We have a lot of theories. We have some theories that have support, scientific support, but we really don't know, and it may not be the same cause in everybody. We know that there has to be a certain genetic predisposition, and it's kind of like this. Everybody's immune system makes mistakes, whether you have MS or not. The main problem that results in autoimmunity, whether it's MS, whether it's lupus, I have psoriasis, that's an autoimmune attack on the skin. The main commonality is a defect in fixing mistakes. So when an immune system makes a mistake, when a healthy immune system makes a mistake, what happens? Typically, an immune cell, let's say some of these cells we looked at, T cells, attack a foreign invader. If it's a virus or a bacteria, it attacks a foreign invader and then it takes a fingerprint, if you will, a identification of that particular organism. And when it kills it, takes its fingerprint, takes it back to the main database that is everything about us that is self. Probably in the thymus gland or the lymph nodes is where this occurs. Checks in with that database. If that immune cell accidentally targeted part of self, meaning you, as foreign and killed it, when it goes back and checks in with that database in the lymph nodes or the thymus, the body is not kind to it. If it did the wrong thing, it's dead. Kills that cell. Your immune system kills that cell and kills the fingerprint it took, so that cannot be passed on to the rest of the immune system. All right, in MS, any autoimmune disease, what happens in that situation is mistake is made, immune cell goes back through the thymus, the lymph nodes, body says, way to go, good job, spread the news to everybody else. Yeah. Then we get what's called epitope spread. There's a whole bunch of immunological terms we can use for this, but essentially it is that mistake is communicated to the rest of the immune system, and the rest of the immune system will forever recognize what was attacked as being foreign. And that's ultimately the problem. Why it occurs, again, we don't know. Is there an environmental trigger? We've heard about Epstein-Barr recently, I think, quite a lot in the news. Yes, absolutely. Clearly an environmental trigger in a genetically susceptible individual. The end result, of course, is the bottom circle, loss of nerve cells. Maybe just myelin if you're lucky, and you can remyelinate damaged cells, but maybe not. So this is a really big change in our thinking. And it's been a very gradual, slow development from a time when we were of the mind that between relapses, persons with MS were in remission. We even named the disease that way, relapsing, remitting MS, at least one pattern of the disease. That's wrong. In between attacks, you may recover, but you're not in remission. The disease is constantly picking away at people's brains, spinal cord, and optic nerves, even if they're not making new lesions on the MRI scan, having new symptoms, having attacks, or anything. We see this in studies where brain atrophy develops or loss of brain cells occur kind of gradually, even between relapses or around relapses. Persons with MS, their brains may be shrinking 2 to 3 times, maybe even 10 times faster than aging, Again, even if they're not having relapses, even if the MRI looks the same, that can still be going on. So time equals brain. The sooner we get people on treatment, the better they do. The data is just piled up on this. It's clear. Early treatment, highly effective treatments, and watching someone very carefully, because treatment may work well for one person and not for the other. And we can't assume that, oh, just pick one. I get that a lot. Well, I'll talk about this later. I get that question a lot when I'm trying to educate someone about all of the treatments we have now. It's great, but it's a little overwhelming. And then people say, oh, just pick one. I don't want to make the decision. No. We'll talk about that later, why you have to be involved in the decision. It's important. But time equals brain. There is a sense of urgency. If you're not on an MS therapy, if you're a preventative therapy, if you're not on a preventative therapy for MS as opposed to symptom management, that symptom therapies don't have the same impact. If you don't take a treatment for spasticity, maybe you're a little more uncomfortable, a little stiffer, have some cramps and spasms, but you don't neurologically worsen. If you don't take a disease-modifying therapy, you will ultimately be neurologically worse. You will have more disability than you would otherwise have to. And then the sooner we get people on treatment, the sooner we diagnose them, the sooner we start treatment, the sooner we respond if that treatment is not working well enough. That's how we can succeed in MS with the current tools we have. I'll talk to you in a few minutes about some of the tools we are developing, but this one's important, and I don't think really just in the past 5-10 years or so have the medical profession, neurologists, started to recognize time equals brain. Again, I'm going to show you this from time to time because this is where we want to be. This is where we all want to be. Quiet central nervous system, no immune cells in there, nerves just working, doing their thing. Fist bumping. I'm going to use that one. Fist bumping along. Okay, let's talk a little bit about vision, shifting gears a little bit. So I think there's a couple ways to think about this. So it's a common symptom. It impairs function, but it can impair function in subtle ways. Obviously, you have optic neuritis and you have painful vision loss in one eye. That gets your attention, but there are other things that can happen. I'm going to give you a little better way to think about this. So in general, to try to understand vision problems in MS, let's think about it in 3 broad ways. What are the sorts of problems that occur? You can have problems with things coming in. You can have problems with things going out, and then processing in between. So that's basically the only 3 ways to think of that. And I'm going to engage you here a little bit. I'm going to ask you to, as we go through some of these visual problems in MS, which ones you think, is this something going in or something going out? Okay, so let's take optic neuritis, for instance. So optic neuritis is going to cause typically painful vision loss, one eye or the other, occasionally both, pretty rare to have both at the same time, it can happen, one eye or the other. This is going to affect up to 70 people at some point, 70% of persons with MS at some point. And actually, there are other studies that have looked at this in people with even early to moderately advanced MS. We find 92% of persons with MS, if we look closely enough, we'll find 92% of people have some evidence of damage in their optic nerve. This is a disease that likes to pick on the optic nerve. It's very common. Some of those symptoms may be mild. Sometimes this is the very first presenting event of someone with MS. The symptoms can be quite mild. You may not notice. Maybe it only shows up with some residual contrast loss, color vision changes, peripheral vision. All of these things could be impaired. Let's take the case of optic neuritis. So the MRI up there, little arrows, are pointing to some inflammation in the optic nerve. That's a contrasted MRI scan. Typically, visual recovery may restart as early as 2 weeks, but initially you start losing vision. Usually there's pain within the first few days. About 90% of the time there's pain. Vision declines 2-3 weeks, maybe levels off up to a month, and then starts to improve. 2 weeks sometimes, if we give you steroids, it might recover sooner. Generally, this was some data found that at 3 months, most people have recovered to 20/40 most of the time. So it's like 90% of people get 90% of their vision back was the rule that I was taught in medical school, actually in neurology school, residency, we call that. And that still is the case for the most part. But again, those residual symptoms, even if you recover, there's often some residual symptoms, things like contrast. So often it'll be people have it in the other eye within 10 years if they've had it in one. I said 92% in one study. And although optic neuritis doesn't feel good, it's not one of the worst things. If all you're having is optic neuritis, if all you had is optic neuritis and a few sensory problems, we don't rate those as highly in terms of prognosis. People are having spinal cord events and having balance and coordination problems and things that are affecting their bladder. Those folks are in a group who are at greater risk of disability. If you had optic neuritis and a couple of sensory problems, we a little less worse prognosis for those. And there are some other, the bilateral I mentioned before. If both optic nerves are involved, there's another disease that might be there called neuromyelitis optica. That's if both happen at the same time. Now, typically, steroids will speed up the recovery. A disease-modifying therapy may prevent this. It's just like a relapse. So it's a relapse of MS that happens in the optic nerve, essentially, and it follows the same course. Ultimately, I wanted to show you this. So the contrast I mentioned contrast is tough. The best way, and I think many of you probably experience this, the best way to know if you have contrast vision problems is on a typical upper Midwest winter day, gray, overcast, kind of cloudy, there's a lot of snow around, and it's really hard to detect the subtle shades of gray. So contrast vision is the most common residual vision problem after somebody has optic neuritis. And it's a vague thing. Patients complain, well, I don't really, yeah, I'm recovered, but I don't really, it's not quite, and it's really hard to describe a contrast problem. We have a contrast vision chart that we can read to measure that. And in our MS Center, we track that. We track contrast sensitivity as well. We measure brain cell densities out of the back of the eye. Anything we can measure about the disease that's going to be meaningful to identifying an incomplete response to treatment, we try to measure. Vision is very, very important, very subtly. So low contrast acuity chart, it's a specialized eye chart, and that may help us in some situations. Ophthalmologists can do this too. They maybe not be quite as clued in to looking for that in MS. I find there's a little ignorance in the ophthalmic community. They know about optic neuritis, but they don't necessarily know about some of the other more subtle things like the contrast loss. Now, this is an attempt to give you an example of what might have happened. If this person had optic neuritis in their right eye and then quote unquote fully recovered, maybe just something subtle. So contrast loss is the most common residual problem. One of the next most common residual problems is color vision, and it can be kind of subtle, just a little blunted. Colors just aren't as bright out of the optic neuritis eye in this case. Okay, now before we go here, so this is vision, pain in the optic nerve. Is this a problem with something going in, something going out, or processing? No one wants to go on record. It's vision. Coming in is coming in. Okay? So optic neuritis, if we think about all the problems that can happen in the vision in MS, this is the most common problem of things that are coming in, okay? Problems coming, vision coming into the nervous system, what you see, even if it's contrast, if it's distinguishing subtle shades of gray or the red car, there's a problem with things coming in. Let's talk about a problem with another area. So the brainstem. We know that roughly half of people are going to have a brainstem problem as their first event. Brainstem controls balance, coordination, dexterity, speech, the production part of speech, speaking clearly, not the thinking part of speech. So the convergence problems, being able to read. If your eyes don't move, when we look up close, our eyes have to bend in like this in order to see something up close, and that can be a problem with brainstem. If the brainstem is damaged enough, there'll be double vision. The eyes don't line up. This is really important, practical. If you ever have double vision, this is the most important observation you need to make. A person with MS or anyone else, whether you have MS or not, this is the most important observation you need to make so your doctors can help figure out what's going on with you. First thing you do if you have double vision, cover one eye. This part's important too, especially if you have MS. Write down what happens. Okay, you may not remember. Cover one eye. What happens to the double vision? Then cover the other eye. What happens to the double vision? I have to pantomime here. Let's see if I can do this. You guys remember Marty Feldman? Marty Feldman was the British comedian who he actually had Graves' disease, and it made his eyes look all crazy. He was bug-eyed, and one eye looked over here, and one eye looked over. He made most of his comedy career out of the way his eyes looked, and he just looked crazy. Well, if you had, as opposed to those of us who remember Betty Davis eyes, this would be a little different. Looking in different ways. So Marty Feldman eyes is very different than Betty Davis eyes. All right, one's looking over here, one's looking over here. Well, if Marty Feldman, if this eye works and this eye works, when he looks over here, he's seeing that part of the room. When he looks over here, he's seeing that part of the room. If he tries to look at someone, he's going to see two different images. Now, what happens when Marty Feldman closes one eye? One image. Closes the other eye, one image. Both eyes open, two images. Now, he didn't have MS. He had Graves' disease. He died a few years back, but he had Graves' disease, but his eyes didn't line up. Same principle. So neurological double vision goes away if you cover one eye or the other eye. Most important thing you can do, write that down if that happens. There are lots of things that can cause double vision. Blurring of vision, dry eye, cataracts, even some retinal things can cause a little doubling. So it's really important to help sort it out. If you have a refractive error, like you just need a change in your glasses. Oh, and there's this one where your arm just gets too short finally. That's something that happens to all of us. I have progressives right now, so that's what happened to me. Happens to everyone. But not everything that happens to your vision is going to be MS related. People with MS are just people. They still get the same things everyone else does. So as doctors, we have to think about that. But we need your help as well. If you have a visual symptom, we need you to describe it as well as you can, especially if it's something episodic that's not going to be there when you go for your neurologic examination or you go to see your doctor. If it's something coming and going, please write it down. One of the most important things, if you ever do develop double vision, if it's a little blurring or haloing around the images, if you squint and it gets better, it's probably not MS, okay? But those are important, just a few observations. And as I said, even if you don't have MS, write it down. You may not remember. Now, other things that can happen, the brainstem also correlates the balance between the eyes, as well as the kinetic, the movement balance between the eyes. So if that gets disrupted, then we get nystagmus and various, what we call the name for that sensation, Emily, that you had with the vertical, that's called oscillopsia. It's the medical term for that. That means the vision is oscillating. In your case, vertical. In some people, many times in MS, we see more in the horizontal plane than vertical. Vertical is a little more rare than horizontal plane problems, but happens. Anything in the brainstem. Now, this is a problem where you see okay. I mean, Marty Feldman sees clearly there and clearly there are two different images, and if you have MS that's causing double vision, you'll see two clear different images, so you see fine. So it's not a problem of things coming in. This is a problem of things going out. Motor control, balancing the eyes, balancing fine motor dexterity, balancing this balance, although there are other ways to damage your balance in MS, the spinal cord, for instance. So this is a problem coming in. Talk about processing only briefly. I want to show you this example. So this is an old slide of mine. I pulled out a very old photograph of a gentleman, and on the top one you see him looking to the right, and the eyes are lined up pretty well. When he's looking straight ahead, they're actually not lined up. You may not be able to see from the back, but they're off a little bit. But boy, on the bottom pane, when he looks to the left, you see that right eye just doesn't move. It's just not going over. And typically, if we had a video of him, and I did have some old videos I couldn't get in here, but when that eye goes out, it's trying really hard. So there is some nystagmus, and this eye doesn't move. So, and that's a classic finding of MS. In fact, if this gentleman was older, and I actually can't remember if it was MS or a stroke, but in older people, sometimes it's strokes in the brainstem. If a doctor sees this in a young person, it is MS until proven otherwise. So very, very uncommon to have this in other than a handful of other diseases, and typically in people who are older. So unfortunately, it's also one that you might recover from it a little bit, but the recovery from this one isn't very good. Often there's some residual eye movement problems, and because other things are damaged too, there's usually some balance, coordination, maybe fine finger dexterity problems that can occur too. So there are ways that we can help people who have vision problems from MS, but we do not at this point have ways that we can reverse those vision problems. Kathleen referred to some research, and there was a question about improvement, remyelination research. Well, we have a few candidates, one that's actually in fairly late stage research that seems to promote remyelination. We have some laboratory evidence of things that seem to support remyelination. Now, remyelination is all about that oligocell, the oligodendrocyte I showed you. That's the name of the game. We can impact those. You can grow more of those. In fact, there's some very interesting research. The MS Society about, was that 2018 maybe, gave their Lifetime Achievement Award to a researcher's last name was Franklin. I can't remember his first name, right? English. He spoke at, I remember him speaking, you can have the driest medical presentation in the world, but if the guy saying it has an English accent, it's just a little more interesting to listen to. He's from, I think he's from Oxford. His life's research was on trying to identify existing stem cells, or what to do with stem cells, or how do we get and ultimately what it came down to is he identifies we have stem cells, for oligocells at least, in our body, within our brains. We have these immune cells, or rather these oligocells, that can be turned on to make new oligocells, even when MS damages, because MS, besides the schematic I showed you, when it damages the nerve, it kills oligocells too. So sometimes you need to regenerate the oligocells. What Dr. Franklin found was that at a very at a very young age, those oligocells will turn, those stem cells will turn into myelin-making cells and will heal the damaged nerve cell. As we get older, those immune cells lose that ability. So he's looking at all the various ways of how we can stimulate those, I said immune cells, those oligoccells. How can we stimulate those oligoccells to start making myelin again and remyelinate? Very interesting things, actually, vitamin D. We don't know if this has any clinical impact on people day to day, but vitamin D makes a difference. Metformin, a common diabetes medication. Clemistine, it's a over-the-counter decongestant, antihistamine type thing. These are some of the agents where we've found in test tube type research that we can actually regenerate myelin. The one research study we have that's relatively late on regenerating myelin, late stage research, phase 2, seemed to kind of be stuck. We can demonstrate an improvement in how the optic nerve conducts, but we haven't been able to really, it doesn't necessarily translate into somebody seeing better noticeably. In a similar way, we can see in animal studies that the spinal cords remyelinate, but it hasn't translated into anybody walking better with the disease. So these are clues. We're not there yet, but we're on the path. As Kathleen said, with the MS Society support and the tons and tons of research going on, there's so much research going on in MS. It's just mind-blowing. It's hard to keep up with all of it now. Anyway, here's some of the things we might be able to do if you have the damage already and we can't remyelinate, we can't do anything else. All we can do really is try to improve the function. So loops, interestingly, the yellow tinted, for that contrast problem, the first thing I tell people to do if they have contrast loss, lightly tinted, yellow tinted glasses. Other important thing, if you wear a sunglass, if you have contrast vision problems, you shouldn't wear a gray or dark lens. You should have an amber tinted lens in a sunglass. It will actually improve your contrast a little bit. Just like a very lightly yellow tinted lens will improve your contrast in the daytime or on those gray, snowy, overcast days. I've told some of my patients, throw a pair of ski goggles, those light yellow ones, throw them in your glove box in case, just in case you ever get caught in a flat lighting situation. All sorts of things. We used to use those. Now they're much more available. You can find shooter's glasses. I have a pair of motorcycle glasses that are lightly yellow tinted to improve contrast. So light yellow tint in the daytime will improve your contrast vision. If you wear a gray tint, a gray sunglass, or if you use those photo gray lenses that change and they change to gray, not a good idea for someone with MS who has contrast problems. When you go out in the sun, yes, your lenses change, but they change gray, and then that actually reduces your contrast a little. So you might need to have a separate sunglass, like an amber tinted, if you have prescription sunglasses, an amber tinted prescription. So a few thoughts there. There are some things that could be done, but right now we can't remyelinate and regrow the optic nerve in any meaningful way that will produce any improvement in your symptoms. So we're still left with compensating for the problem. And these are a few ways we can compensate. Okay, again, here's where we want to be. Healthy nerve. Well, as Kathleen said, the Shapiro Center is a partner in care with the MS Society. As I mentioned earlier, the ways the MS Society helps my patients and helps us take care of them is just phenomenal. I've practiced in several different situations. In fact, the only situation I've never been in is a solo, private, independent, doctor hanging a shingle, kind of like, the old Marcus Welby days, right? I have found in every single way deficiencies in when I try to take care of a person with MS in a typical clinic model of care. You come into the doctor, you come into your neurologist, you see the neurologist taps on your reflexes and talks about your disease-modifying therapy and your MRI, and then off you go. I was always dissatisfied. And especially as I learn more and more, there's more and more we can do for people, but can't really do it in a 15-minute clinic visit. Primary care doctors are under a tremendous amount of pressure now. They're supposed to see you in 10, 15 minutes, document your encounter, get all that done, make sure they all your health maintenance, identify any problems. No, it's hard. Well, same thing with taking care of someone with MS. It takes a village. I think we've heard that. First time I heard that, I had 2 boys 14 months apart, and yes, I understood what that meant in that context. It takes a village to raise a child. It really does. It certainly takes a village to care for someone with MS. Much more than what the typical doctor's visit offers. So comprehensive care centers developed out of this sense. Now, I had this happen independently. Been talking to Dr. Shapiro. Randy knew Sylvia Lowry. He used to hang out in her apartment in New York where they were planning all sorts of things and on the ground floor of the MS Society. So, but he was a little later. He was definitely later than Sylvia. She was there before. But Randy knew then. Randy's mom had MS. So he had a sense of what people with MS had to live with, and there wasn't any support for Randy's mom. There weren't disease-modifying therapies available. So Randy had that sense. Randy knew very early on that, boy, trying to take care of people, even in a hospital setting or a clinic setting, was really difficult. So Randy and a few others, I could name them, but you wouldn't necessarily know their names, went on to develop consortium of MS centers. That was to meet the needs of healthcare providers. At the time, we didn't have that term. We called them doctors then, but we didn't have nurse practitioners when he was doing this. We had nurses. And Randy was always about the nurse is the center of the MS center, not the doctor. The nurse is the heart and soul. It still is. Now we have advanced practical nurses, various other support. So now we actually have a healthcare provider team. Now, comprehensive care is a little different. It takes a different approach, tries to meet the needs of the person. Try to be a one-stop shop if you can for all things MS and connect people with the best resources in the community, including the MS Society, including other providers. I'll go through a few slides that'll make that a little more clear. This middle bullet point, psychological support. Psychosocial support, I think, is one of the things that often is forgotten in a way that the MS Society really helps out. The MS specialist becomes kind of almost becomes your primary care doctor for MS. And I've got to tell you, we do a lot of primary care. We treat bladder infections. I find some primary care doctors will say, give that a little while. It might go away. No, if someone with MS has a bladder infection that's not treated aggressively, they could easily wind up in the ICU with sepsis and maybe even die from it. So we tend, I've been asked by, there's a family practice journal in Minnesota, and I just don't have time to do it. They've asked me to do an article, and the one I want to do is MS through the lens of primary care. I want primary care doctors to understand things about MS that they don't currently about people with MS. By the way, another important, if you have MS, you need to know what your body temperature, what is your normal body temperature. You need to know what your normal body temperature is. It's not 98.6 more than likely. Most people with MS, if they've had MS for any length of time, run a lower body temperature. If you show up in an emergency room with a bladder infection, and let's say you don't have good sensation anyway, but maybe you show up because the bladder infection is causing your spasticity to worsen, you may not even know you have a bladder infection. First thing they look at is, do you have a fever? And if your body temperature normally runs 97.4 and you show up with 98.6, they're going to blow you off because they don't know. So you have to tell them. This is the advocacy part. So everyone who has MS should check their body temperature times when they're not sick and just get a sense, morning, evening, a few times a day, just get a sense of what is normal for you. One of the most important things you can do in case you do have an infection, because most of us are going to have an infection even if we don't have MS, important to know. Let's talk a little bit more about comprehensive care. So this is from an article. I know these are folks, Harris, Costello, Halper. This is the core MS. There's an International MS Nurses Society and the Consortium of MS Centers. So this was from a publication today. I agree completely. So having a team, ideally in a single facility. That team should be composed of primarily, most important thing is a knowledgeable person with MS. That means you. That means in a comprehensive care paradigm, you have a responsibility too. Now, we have a responsibility to educate you. You have a responsibility to be educatable, and educate yourself and to stay informed. So that means we will put demands on you. I'll talk about that a little bit when we talk about shared decision making in just a second. So knowledgeable individual, the person with MS. We have to loop in the friends, family, care partners. The MS specialist belongs there, but boy, other specialists are really important too. If you have kidney stones, a family history of kidney stones, and we want to treat you with vitamin D, that's could make your kidney stones worse. Vitamin D might make slow down your MS. Well, sometimes you might have to send you an endocrinologist. If you have a bladder problem that we can't fix, we'll send you to a urologist, for instance. So other specialists. And then the support, the nurses, the social services, psychologists, physical therapists. I mean, this is the team. You don't get this in a typical doctor's office visit, nor does that doctor have the resources necessarily or even the time. So this is why comprehensive care centers evolved. This is what Randy and Sylvia Lowry and June Halper, Kathleen Costello, I think it's Colleen Harris. This is what they talk about all the time. How do we expand? And these conversations were going on when the Consortium of MS Centers was being started. Actually, that was mostly with June. The other ladies came along a bit later. So this is what it's all about. So the MS patient connects to the MS specialist, and we have to have connections to all of those providers and all of the other specialties. It really takes a village, and on this slide doesn't even loop in what support partners and your family and your friends do and how necessary they are for persons with MS. So it's very important, again, something that the MS Society helps to corral and help coordinate and educate support partners, educate persons with MS. So hugely, hugely important to what I do in the clinics. So this is essentially a synopsis of that village, if you will. Now, comprehensive care is different. Oops. In the little orange thing in the center, there's supposed to be the person with MS in there. That dropped off this slide. So, so we have to think more than, oh, there it is. All right. More than just the team or the community. We have to think more. The person has to be at the center. The person with MS is at the center of the paradigm. So all of these are important. All of these spheres come together. But primarily focusing on the needs and the psychological support and a lot of the things we've heard that the MS Society can do. Now, same paradigm we can look at in terms of shared decision making. I chose the option of selecting a disease-modifying therapy for a patient. This is probably one of the most important decisions that anybody with MS is going to make with their physician. And I say with their physician because it should be with. Anybody ever had a doctor? I mean, if you go back a ways in MS, and I hope it's not happening too much now, but back in the day, there were neurologists who were diagnosing people with MS and handing them 3 kits from the drug company to say, take these home, tell me which one you want to take. You know, I don't know. So, well, now it's not, things are not nearly as simple now. We have, I've lost count actually. I don't even bother counting the actual number of MS therapies we have. Now I tend to focus more on the classes of therapy. I'll talk to you about a class that's in development is our kind of some of our late breaking stuff I want to get to right at the end. But so we have so many options now, so many ways to impact the immune system, so many other ways we can do good or do harm, other issues, different side effects, different risks from the therapies, different efficacies of the therapies, effectiveness of the therapies. So it's so much more complicated than when we just had 3, basically, actually we had 3 drugs, but it represented 2 classes of therapy, 2 ways we could impact the immune system. Now we have, I think it's 12, soon to be 13, I've lost count. In terms of, you too? Yeah, I can't keep up, yeah. Oh, that's drugs. I'm trying to think of the classes of therapy. So a class represents a mechanism of action. So for instance, take an interferon drug. The very first drug approved to treat MS was beta-seron, and shortly after that, Avonex. They're both interferon drugs. They're slightly different. Avonex and Rebif, the same drug. They're exactly identical molecules. So that's a class. They're all one class. They have the same side effects. They're very delicate molecules. They have to be injected. They can't go through the gut or they break down. So similar side effects, injection site reactions, flu-like symptoms, lowers your white blood cell count, those sort of, all the same. Other classes of drug, other end of the spectrum, a drug like Tysabri, a biological drug. We'll talk more about biologics in a minute. Biological drug. Very potent drug, intravenous infusion, whole different set of side effects. PML, progressive multifocal leukoencephalopathy, fairly serious risk that could happen. So that's just an example of we've come a long way. We have a lot of different mechanisms of actions, ways we can impact the immune system. And it's important to make sure that in this process, selecting a treatment, that we consider all the things that are important. Things that are important to the disease, things that are important to me. I mean, this is sort of how I start this discussion. You know, from my side of the desk, this is what's important to me. I want to save brain cells. The number one thing, the most precious thing that we have in our body that we cannot grow anymore are neurons. We can't grow them back. So I want to prevent that loss. So that's one of my first goals, and I tell patients that when I first meet them. First thing I want to do is prevent and prevent and prevent. I want you to keep as many brain cells as we can right now because we're going to get better treatments. I don't know when we're going to get a treatment that's going to regrow brain cells. I can see on the horizon a treatment that can remyelinate the damaged ones. So let's prevent as much damage, the relapses, even between relapses, that loss of nerve cells, that gradual loss of brain cells that can be going on. That's what we got to stop. So that's my goal. Now, on the other side of the desk, you guys have a life, right? We could have the most effective treatment in the world, but if it was either too risky or too expensive or too many side effects, it wouldn't do us any good, right? We have to find a treatment that is going to work for the individual. And we have to consider other things than just like, will it suppress your MRI? Will it keep you from having relapses? Ultimately, absolutely, it's important to prevent disability, but at what costs? So balancing the risk of the treatment with the risk of the disease becomes very important in selecting this therapy. We also have tons of data now showing that in that situation where we hand out 3 kits to someone and they pick one and they don't really understand what they picked or why they picked it just because, well, it had the best marketing, the pictures were the best, I like this one, I don't know why, I can't tell you why. That situation, someone gets few side effects, we have research that shows they're way more likely to say, I'm not doing this. When we educate people about the treatments, when we educate people about the disease, when we educate people about the things that we can do to prevent them developing disability, and sometimes I have to educate people about what disability in MS would really look like for them in the real world. So, not to be alarmist, but I've had this question asked of me, where a goal of a patient is, these are older questions, or questions from 10 plus years ago, I want to be able to walk down the aisle to my daughter, son's wedding, et cetera. Goals like that. And those are still things to keep in mind, but I think with the tools we have now, we're better able to prevent some of those things, but not always. There's one big elephant in the room in MS of all when we talk about therapies, and that's progressive disease. That's an hour-long discussion right there, but we have so little for progression right now. That is the one where I really wish, and the MS Society is sponsoring research, everybody's researching this. We have some hopes for the last group of drugs, and I talked to you about the BTK inhibitors, maybe, but hitting that slow progression. Anyway, in this conversation here, the shared decision-making goes like this. I generally spend about 20, 30 minutes going through a list of the treatments with someone. This is someone maybe brand new, or even if we're changing treatments, new diagnosis. I go through those treatments. I kind of give an outline and say, all right, I try not to really say, you should take this one, you should take that one. Because I think when I do that, people suddenly just stop thinking about it themselves. They go, okay, well, he knows best, I'm going to do that. I want my patient to be educated to understand why we're selecting treatment. If we pick a treatment that has a risk to it, and they're nervous about the risk, they need to understand that we're balancing the risk of the disease. So I wouldn't select a highly risky therapy for someone who likely has very mild disease. So when I first meet someone, very first thing I do, I spend a lot of time looking at their MRIs, doing their examination, talk to them a lot. What happened to you? When did your MS first start? How did you recover? Did you get steroids for relapses? Did steroids work? Did you have any relapses on a treatment? All of these are important questions for me to determine the risk of the disease for that individual. Well, I don't, and I shouldn't decide. We all have free will. My deal, and I tell my patients right up front, I'm not going to tell you what to take, okay? This is collaborative decision making, okay? Shared in this model. Collaboration. We're going to talk about all of the therapies. We're going to go through the pros and cons. Takes an hour. My staff hates it. They know if I go in to have this conversation, clinic's going to be late. Another patient's going to be upset because they waited an extra half hour or so because Dr. Calkwood was talking about the treatments. Most important thing you can do before you go on a treatment is to understand that treatment and all the other options, pros, cons, as well as what it means to your life. And I can't make those decisions for you. How often do you want to get labs? Do you want an IV? Do you want the risk of this? Are you going to lie awake at night if you're JC virus positive and could get PML? Are you going to be lying awake at night anxious that you might develop PML if you're on a drug that could cause that? I can't make those decisions for you, but it's important, and someone needs to help you understand. You make the decision. We guide you to the right ones. We make the decisions together. So collaborative or shared decision making. That's essentially what it looks like. I don't think if I weren't in a comprehensive care format that I really could be collaborative. I think I would never hand out 3 kits, but I might get to the point where I say, oh yes, I do know best, here, you take this one. But with everything we know now, first rough spot, that person may stop the treatment. One of the things I hate the most, someone with MS, I've seen this actually over and over again, sometimes, various things. A young person comes in, they have MS. Diagnose them, we start talking about treatments, they freak out. I see them again a year and a half later. They were walking and talking and chewing gum at the same time when they came in. They come in a walker, or worse yet, a wheelchair. I had one young lady, this was crystal meth. She went down the crystal meth hole, and that's really hard on MS too. But don't take crystal meth. Do I have to tell anybody that here? Okay, don't do crystal meth. It's really bad for MS. Crystal meth, crystal meth and MS. Cigarette smoking too. Maybe not as bad as crystal meth, but almost, really. So it makes MS worse. Other health issues too. Now, geez, I lost my train of thought. That's happening to me as I get older. I told you 35 years of treating persons with MS makes me old. So crystal meth, yeah. Going down that rabbit hole, coming back out. If we delay treatment on someone, if we delay treatment even in a year or two, we know that that's negative. If that person gets freaked out, if they're not educated. So shared decision making, especially when it comes to disease modifying therapies. But really you apply that to everything. You should be educated about the side effects of baclofen, the side effects of gabapentin, any of the common medicines we use. You should be educated about what if you don't take a disease modifying therapy, what's going to happen. So, and it's time consuming. And that's where my team, my patients, my staff makes such a huge difference. The support of the community, resource of the MS Society, various physical therapists, social services, psychologists, we a comprehensive care center. If we don't have the service to provide, we want to connect with the best of the best for persons with MS that's available in the community. And again, I think the MS Society tends to help out there too. A lot of the people we work with wind up working with the MS Society too, so we stay connected. Okay. Deep breath. We're going to talk a little bit about some things that have to do with generics and biosimilar. Do you guys understand the difference between a generic and a biosimilar? Any sense of that? So a generic, so there's a trade name drug. So when a drug is first approved by the FDA, it's given a patent. It takes a lot of money that a drug company to develop a drug. And so they invest a lot of money. They want to recoup their investment. We want a healthy system that develops drugs. So I think when we hear about the cost of these drugs, it's outrageous. And I think that it is, especially when we look at what's paid the cost in other countries. In the U.S., we have very high drug costs compared to some of the European countries even. So generic drugs, generics and biosimilars, first of all, would be a way to lower costs. And that's kind of how it's being looked at when we talk about FDA and various other bodies. Lowering costs of treatments, making treatments available to more people who wouldn't otherwise have access to disease-modifying therapies. So a generic drug is a copy of a small molecule. Now, a small molecule is something that can be easily reproduced, and you can often test it in a test tube or in a laboratory to get a sense that it has a similar impact to its trade name. So that's typically what a generic drug would be. Anybody ever taken Ampera? That was the walking speed drug. Gosh, I hope someone's had some benefit from that. No? Okay, one. So Ampera went generic, dalfampridine, okay? So that's a small molecule drug. So various other drugs, baclofen used to be called Lioresil. That was the trade name drug. That was decades ago. And now the most common form of baclofen is baclofen generic. However, our MS therapies, the disease-modifying therapies, generics are pretty new to us. And biologics and small molecules are different. So a small molecule is just that, something you can actually make pretty easily in a lab. It's easy to reproduce. If someone has the method to make it, they can pretty much make it in a different lab. Biologic drugs are different. Biological drugs use some biological system, typically cell cultures, tissue cultures, to harness the metabolic machinery of the human body to actually produce a substance that, in this case, would treat MS. It's kind of like using the immune system to treat the immune system. So we use these monoclonal antibody drugs, are the most common class of biologicals in MS. Copaxone and generic Copaxone too would be considered biological drugs. So a biological drug has complex interactions throughout the body. It's more difficult to do an assay. We can compare a biological drug under an electron microscope and measure it, various ways and say, yeah, this seems to be identical. But we don't always know that it's going to have the same impact. So biological drugs cause complex interactions through the body. They're very difficult to produce. Tissue cultures and cell cultures are difficult to maintain. Even between batches of different tissue culture or different batches of the drug can be slightly different. So quality control is really important. Consistency of the product that the pharmaceutical industry has to ensure. Very difficult. As a result, the FDA extended a longer patent life to biological drugs. So small molecule drugs, shorter, gosh, I don't remember, I think it's like 7 years, something like that for small molecules, but 14 or longer for biological drugs. So, and that's them simply recognizing that if the research that developed, the cost of the research to develop the drug, if that doesn't eventually come back in some way, we won't have any more research. So this is an acknowledgement of some of those issues. So let's talk a little bit about generics and biosimilars. So, and now this is all pretty much referenced from the FDA's website on biosimilar drugs. So biosimilars are coming. We have one now. So Copaxone, generic, and copolymer one. Several actually. So biosimilar drugs are essentially going to be the reference product, meaning the first drug that was approved by the FDA. And then the biosimilar comes along that is similar, if not identical, at least very similar. They have to show in some way that the biosimilar drugs are similar enough in that there is no clinically meaningful differences in terms of the safety or the effectiveness of the drug, amongst other things. And actually, if a biosimilar is approved for any indication, it can be used for others too. So that's just a few rules that the FDA have. So there is a rigorous process. It's multi-step. It looks at both the effectiveness, the safety, and can they be reproduced consistently. And these are all very important things the FDA looks at. They then compare to the reference product. They've approved that reference product as a standalone drug. But ultimately, the goal of the biosimilar development program is to demonstrate, from the pharmaceutical companies who is applying, is to demonstrate that that drug is identical in as many ways as they can. Now, what the FDA is not requiring is to show that it has identical effectiveness. So that's probably the main difference between generic biosimilars compared to the trade or the reference product, is they don't necessarily have to do expensive clinical research to show that they had the identical effectiveness. In some cases, depending on the product, the FDA may require them to drill down and do a little more effectiveness research, or efficacy is the medical term. So these are some of the data. As I mentioned, this is all kind of boring. Pharmacokinetics. Does the drug come into the body the same way? Is it eliminated the body the same way? So pharmacodynamics. What's the blood level immunogenicity? Is it going to cause the immune system to react to it where the other drug doesn't? These are all, again, some of the issues that we have to keep in mind for the biosimilars, and this is what the FDA goes through in a rigorous process to establish their safety and effectiveness. So, do they work? Does a biosimilar work as well? Most important question. What I say, time equals brain. That brain cell is the most precious thing. We don't want to give up even one of them. Well, this is a meta-analysis. Meta-analysis is where you don't do one study, you study a bunch of studies and you use statistics to put all of those things together. Sorry, it's getting hard. So So there was research. So this is a meta-analysis to basically say these drugs, in looking at all of the studies on biosimilars and putting them there. This is not just MS. This is biosimilars across every disease state of biosimilars. And you can see the reference down here at the bottom. So there were, of the 90 different studies that they reviewed on switching from the FDA-approved trade name reference drug to the biosimilar. This was 14 different disease states, 7 different biosimilars is what they looked at, over 14,000 people. That in the majority of those publications, there were not any differences seen. So this does give us a little confidence, even though those drugs aren't tested for effectiveness to the same rigor that original biological drug is subjected to. They are closely studied, and a lot of data is required by the FDA. Even if they are able to cut a few corners, that reduces cost, and it gets more treatment to more people. And that is some of the primary goals that the FDA had. There is an initiative underway to promote further development of biologicals at the federal level, so I think we'll see more and more of these develop. We'll get on to questions at the end. I'm sure you're going to have some about this. All right, I'm going to mention, there's so much going on in emerging therapies. I'm going to mention one class that looks particularly interesting. I have to say interesting right now because we're right in the middle of evaluating this class of treatment. So BTK stands for Burton tyrosine kinase inhibitors. So BTK is an enzyme. This is the very first drug in MS, first treatment in study in MS that works on enzyme systems. That's unique. The other thing that's unique about this class of drug, completely different mechanism of action, in part because it works on this enzyme system of Burton tyrosine kinase. Now, kinase, when you hear that, kinase is an enzyme that cleaves proteins. There's probably millions of them in our body, thousands at least that we know of. So in this case, this particular enzyme has impacts throughout our bodies, not just on the neurological system, not just on the immune system. Couple novel things it does. We have different aspects to our immune system. When we are born out of the box, we have a functioning immune system. It's called our innate immune system. Innate immune system, skin's part of our innate immune system. It's a barrier, but innate immune system will react to a foreign invader immediately. Then we have another aspect of our immune system called the adaptive immune system. That's the part of our immune system that recognizes foreign invaders and then remembers. So if you had chickenpox, okay, you'll have antibodies in your blood to chickenpox. Your immune system remembers chickenpox, all the childhood diseases. So that's your adaptive immune system. The example I gave earlier, the immune cell that makes a mistake, and in the genetically predisposed individual to autoimmune disease, that immune cell isn't, and that immune cell is allowed to propagate that wrong attack to other immune cells. That's your adaptive immune system, and that's the part of the immune system we have most of our MS treatments has focused on. So this is an exciting group of compounds because it also affects the innate immune system. And there is one really critical immune cell. I won't bore you with all the names and things. It wasn't actually in our original diagram. But one critical cell important to MS that is in the innate immune system that we are not impacting and that this class of drug does. And then one more very, very important thing is the vast majority of the MS therapies we have now do not work in the brain. They work on the immune system somewhere outside of the brain. They keep the immune system from getting into the brain, first picture versus second one I showed you near the start, or maybe they reduce some inflammatory cells, maybe they sequester, keep those inflammatory cells in the lymphatic system, various mechanisms of action. So this would be a novel mechanism of action of a drug that not only impacts a different aspect of the immune system, but also does penetrate inside the central nervous system. One of the things I didn't show you in that schematic of all the immune cells in the brain, that's an interior schematic. On the surface of the brain, we found in MS, the brain is not supposed to have any immunological activity in it. Unless you have an infection, there should not be evidence of the immune system active in your brain. In persons with MS, especially if they had MS a long time, and especially if they're kind of slowly worsening, secondary progressive MS, we see clusters of immune cells sitting right on the surface of the brain, in the meninges, the coverings of the brain. And these immune cells are doing lots of things, releasing antibodies and chemical messengers we call cytokines, chemical messengers that the immune system uses to communicate. So since most of our treatments work in the periphery, only a few of them penetrate into the central nervous system. We really think that these germinal centers, in fact, we can even see this on MRIs. If you do a high field strength MRI, like a 10 Tesla, typical MRI you get is a 1.5 or a 3.0 Tesla. I don't mean cars. I mean Tesla is the right strength of a magnet. So a 10, these research magnets, 10 Tesla MRI, you can see the very surface of the brain in great detail. And where these little germinal centers are, these collections of immune cells, it's like moth-eaten right next to them. So we know they're doing something, but we don't have anything that impacts them. We have a lot of hope for this drug. And I have to say hope. I'll show you just a little bit of the research. It's very early on, but BTK inhibitors are going to be the next new class of drug, completely new class of drug, new mechanism action that we're going to get. So I'll show you a few of these. This is tolebrutinib. Oh, by the way, you can kind of group your drugs by how they end. The NIB inhibitor, these are all the BTK inhibitors, the NIBs, all right? Let's see, the MOBs, if it ends in MAB, okay, it's a monoclonal antibody. There actually is a reason. All these crazy names we get for drugs, there's actually a little bit of reason behind it. You still can't pronounce them any better, but there's a little reason behind it. So MAB, monoclonal antibody. If it's a humanized monoclonal antibody, it's UMAB. If it's more of a murine or a mouse, it's IMAB is the ending. So those are all just interesting things. I don't know, trivia. There's going to be a quiz later. Did we tell you that? Okay, yeah. All right. No, there won't be. No, won't be. As we look at one of these drugs, here's some recent research, a phase 2 study, kind of looking at the dosage. And if you look at the top, diagram there, I just took this out of the study. You see the reference here on the bottom. Essentially, they have placebo, then they have 5 milligrams. So that top one is basically T2 lesion count, so the number of MS lesions. So if you look at this, and it shows you along the bottom, these are small studies, I think, a phase 2 study. Do you understand the FDA's development program? There's proof of concept where you say something likely to work. Then it gets to something called a phase 1 where you just test it and make sure. Maybe you do just a few human subjects at phase 1, very small studies, really focused on safety. Then you get to phase 2 where the focus is on safety, but you really start then looking more detailed effectiveness, but the focus is still safety at phase 2 and some degree of effectiveness. And then phase 3 is where these drugs really prove their mettle in a very large clinical trial that often takes years, and the development program of a drug from the time they start a phase 3 maybe 4 or 5 years before that drug's actually approved, and it may take 10 years to get it to phase 3. These studies might cost, a phase 3 study might cost $80, $90, $150 million. I mean, it's a lot of investment that the drug companies have to invest with no guarantee that they're going to make their money back. So anyway, the phase 2. So we're at a phase 2 here, and what we see is fairly clearly is there was a reduction of new and enlarging lesions, and there was a reduction of active lesions on the bottom. And it's dose related. So I don't know if you can see in the back, but it's placebo in the green, 5 milligrams, 15, 30, and that one looks like 60 milligrams. And then same thing along the bottom. And you can see, again, small numbers of patients in a typical phase 3 study is going to have 800 to 1,200 patients in it. A phase 2, 100, maybe 75. something like that. So a little bit different rigor of research. I mean, much more focused on safety, as I said. So, but we start to get a sense of two things. One, does it work? And two, what is the dose that's going to work? So as you can see pretty clearly here, if this drug, if they design the next research study and they study the 5 milligram dose, they're probably not going to make their money back, right? So can you see that? The bar, and then the higher the dose, essentially, as you go from left to right here with those little bar graphs, better and better. So the smaller bar is the best, and that's out at the 60 milligram dose. So not only does the study help figure out what dose is going to be the best dose to explore, and is that dose safe? Okay, those are some of the key things that we do in a phase 2. So right now I can say hope, okay, promise, but we need that phase 3 data. That's really going to tell us where they hit the mark, if they hit the mark. So far, changes on MRI and relapse rates, and ultimately disability is what we look at to determine if an MS therapy is effective. But in the phase 2 studies, we tend to look at things like maybe relapses, MRIs. Those tend to be in secondary or tertiary endpoints, might be something like someone's disability. But those types of measurements you do in a research study are much more difficult, and it takes more money and more time and more patience to meet the statistical needs to prove a concept. So larger numbers, more expensive. So this is a phase 2 study as well on another BTK inhibitor called evobrutinib. Again, NIB. So you know it's a BTK drug. The little graph on the top just basically says everything on the left of that vertical line favors evobrutinib as being more effective than placebo. So as you can see with this drug, also a dose ranging, we can see that the 25 milligram dose is actually on the wrong side of the line. Okay, doesn't seem to be any better than placebo. Although the bar extends a little bit across the line, but the little diamond is where the center of that is, and it doesn't favor. Basically, says placebo did as well, maybe better. Then we look at the 75 milligrams once a day, and the 75 milligrams twice a day. Now this one's going to be a dilemma because, boy, 75 milligrams once a day and twice a day, and of course, I'm sorry, I said placebo, but dimethyl fumarate was also in this comparison. So 75 milligrams twice a day didn't seem to be much better than once a day. Well, so that may advise them on what to do with the next study. Are we going to study 75 milligrams? Now, the other thing they would look at is say, well, gosh, people taking 75 milligrams twice a day, did they have more liver problems or some side effect? And that might inform them. So this is kind of a very important. Sometimes they do a dosage ranging long before they get to this stage, just to even know to try the 25 or the 75 milligrams. But at this phase 2 level, this is an important concept. Now, if we look along the bottom, we can see this was actually, so relapse rates on the top, and at the bottom chart, you see actually the lesions. So the lesion, I think that was lesion volume that they used there. So same thing, placebo versus 25 milligrams once a day, didn't seem to do that much. Here, 75 milligrams once a day, and then we see 75 milligrams twice a day, and then at the very far end, you see what dimethyl fumarate, which would be generic Tecfidera, what dimethyl fumarate did in terms of lesions. So there actually was an explanation in the research study, and I don't remember it, for why dimethyl fumarate was worse than placebo. There was a kind of fluky reason why that happened. Dimethyl fumarate does work better than placebo. This is misleading, so don't draw any conclusions. So in this case, the 75 milligrams twice a day actually had a little more impact on reducing MRI lesions. So maybe they do want to study the 75 milligram twice a day in a phase 3 study. So that's an example of how I would use the phase 3 program, or phase 2 program rather. All right, one more to talk about, and there are more, and there'll be more coming, of these BTK inhibitors. Fenebrutinib, this one's got a phase 2, that should also, it should be phase 2 and that's supposed to be a 3 trials in primary progressive. Actually, I'm sorry, that's supposed to be not PMS, but relapsing MS. That's a typo. So phase 2 and phase 3 trials in relapsing MS and a phase 3 trial ongoing in primary progressive, but I don't have any results to show you that one yet. So, so this is interesting. A lot going on. And this is just one class of development. Now, this is something I'm thinking about right now. Drugs that are made by enzymes, or drugs that impact, their mechanism of action is on enzyme systems. These BTK inhibitors are going to give us a little bit more trouble, because the class effect thing, when, if we put someone, if we give you Avonex versus beta-seron, we know, okay, you're going to have very similar things. But these enzymatic therapies, a slight change to the affinity, the way the receptor, the way it binds to the receptor, or what receptors it binds to in the body, might make a really big difference, not only in the effectiveness, but in the safety. So I think this is going to be a bit of a challenge for us, because we can't just lump all the drugs together and say, oh, the interferons, they all do this, and oh, the S1P drugs, the Gilenya-like drugs, they all do this. I don't know we're going to be able to say that about these. I think each drug's going to have to stand alone. Now, if you think about that, fortunately these are small molecules, so we'll be able to. When we do get to generics down the road, we won't have those concerns. But for right now, each drug we're going to have to figure out, and when a new drug comes out, we're going to have to really know its individual side effect and risk profile, as well as how effective each drug is. So I don't think we can make sweeping generalizations about this group of treatments just yet. And I think I have one. Oh, the red didn't show up. Breaking news. So this is something that happened fairly recently along the lines of a biosimilar. So I mentioned Tysabri earlier. July 25th, this is from an article published on the 25th, it was just prior to that Novartis has applied to the FDA for a generic, or rather a biosimilar version of Tysabri. So we're hopeful that this would be a way to lower the costs, create a little competition, and hopefully lower some of the costs of these rather expensive drugs, as well as getting more access for more people to some of these biological drugs. So I think that's about all I got for you guys. Yeah. Don't tell me I'm any close to on time. No, I'm never on time.
We're at, so.
Oh, no. Those are, I hid those.
Okay, well, let's give the doctor a round of applause. Okay, so I got a lot of questions for you from online, but one of the first ones that we had, we're going back to the biosimilars again. All right, and a person is asking for you to re-explain the biosimilars. And we're going to just pull up a screen that had something about it, that screen right there. So I just didn't know if you wanted to, say again what they were asking about. And also, you brought up a point of view of its pricing. Is there any pricing available for that yet, or are they thinking about how that's going to be affected with going like against the brand drug that's out there right now?
I'll take the last one first, I think, as far as the pricing. In general, what we've seen when biologics or generics become available is they are priced lower. The cost of developing the drug is less. And then the ability to price the drugs lower. So in general, that would be our hope, that we develop some, that this competition would cause a decrease in pricing. The first impact we see usually is insurance companies adopting the generics or the biosimilars, and so that often lowers the cost for the insurance company, but in some cases there may not be copay assistance available or to the same degree. So these are some cost things. Sometimes there's a bit of a trade-off in cost, but in general, more people gain access when there is a biosimilar or generic drug available, and more people, and the cost to the system, if unfortunately not the individual, is less. And often there are other ways to compensate for that too, and some of the generic companies do have support available for the product. And I'm sorry, Stuart, the first part of the question was re-explain biosimilars?
I think that they got it. I think that first off, for anybody that's asking about to re-explain about the biosimilars or anything else to do with the program, I don't know if you were taking notes or not, but you don't have to because it's all being recorded. Everything from that took place today is being recorded and will be on the MS Views and News Learning channel, okay? So we won't have to go for that. We have so many questions. I want to get to a few other things. You were mentioning about a person's temperature earlier, all right? And so, you were saying it's very important when you go to a hospital, for instance, that you let them know your temperature. What if the person is not coherent to bring that up and things get worse?
Yeah, so when I was saying it takes a village, that's where you need your village, right? If you're incapacitated, then your care partner or support person or someone close to you has to know that too. So didn't maybe emphasize that enough in the presentation of just how important the support partner is. But again, shout out to the MS Society because they support not only the patient, but the person with MS, but they support those who care for people with MS.
Okay, thank you. Going to another thing. So the bit about doing programs in rural America, I know that there are a lot of organizations that are doing programs in rural America, but what can you say? What's that?
Are there? Actually, not for MS.
Well, MS Views and News is out there.
You're the only one I know about,
okay,
actually.
That's good. Well, I think that Can-Do was doing it as well. Weren't they, Kathleen? Can-Do was doing this with... Right, exactly.
Yeah. Can-Do MS, they probably don't do as many outreach. They used to do a lot. I was when it was the Yuga Center, I was Yuga staff. So
sure.
Those are great programs, and they're not doing quite as many. I think that's picking up a bit more now, but that's good. Yeah.
Thank you for that. Is there anybody in the audience with a question, or I'm just going to get right into all these online questions? All right, well, I know about. She's always got questions. So I'll be back to that one in a few minutes, but let me go with some of these online ones, and because there's a lot here, okay? All right, so the first one, going to the portion about visual aspect, a person is asking, can myopia be an early symptom of MS?
So myopia is the term for nearsightedness, which is just a crazy way to describe things, right? Nearsighted means I'm sighted at near, I can see well at near. Farsighted is I can see well at far but not near. So nearsighted myopia. So myopia results for most people due to the result of having do I have to say we're all, none of us are identical, we're all different, right? So, and our eyeballs are different too. The shape of our eyeball. So a myopic eye has a long, skinny eyeball. It's more oval shaped than it is perfectly round. So myopia actually is directly related to two things. One, the shape of the eyeball, and the age of the individual in terms of their ability to compensate for it. When we're younger, we can kind of, like everything else, we can overcome a little bit more. But no, myopia is not a symptom of multiple sclerosis. It may cause blurred vision, and if someone's vision is excessively blurred, they may describe it as doubling. I draw a distinction when I'm asking people about their symptoms. If I really try to focus on that, and I've trained my nursing staff as well on the phones to do this, to say, well, and they ask the same questions I do, cover one eye, cover the other, and what happens, et cetera. But if you see double, besides covering one eye, covering the other observation you want to make is, are you seeing two distinct, separate images? Remember, Marty Feldman, right? Two very different things, right? If you're seeing two distinct, separate images, or are they overlapped or haloed? If they're mostly haloed, what you might be experiencing is blurred vision. So blurred vision can be confused, or myopia can cause blurred vision and cause some of that haloing. Now, if you have myopia, here's let's take this example because this will point out a nuance to the cover one eye, cover the other eye thing. So let's say you have myopia in just one eye. It doesn't usually work that way, but for these purposes. So if you have, so you're going to have blurred vision, and maybe you see haloing of the images, and maybe you're going to call that doubling, and you walk in to see your neurologist or your doctor, and you say, I have double vision. And then they say, well, what happens when you covered one eye? So let's say you didn't quite, maybe you nodded off during my presentation and you heard the part of cover one eye, but you didn't hear a part about cover the other, and then didn't hear about write down what happens. So if you covered that eye, the eye with the myopia and blurred and halo, and you're saying I have double vision, you cover that eye, it goes away, and you tell that to your neurologist over the phone, they're going to go, uh-oh, got to give you steroids if you have MS, right? But you got to do the other step too. So if you have double blurring halo, you cover one eye and it goes away, you have to cover the other eye. You go, cover one eye, it goes away, then I cover this eye, and it's just as bad as it was with both eyes open. So that is a problem with just one eye. So probably not neurological. Could be optic neuritis if you have pain and eye movement, but probably not neurological, at least not for the double vision part. That's just a problem with one eye. That is not MS. That could be myopia, or the other thing we call a refractive error. Refractive error is something that can be fixed with glasses. So things that happen to vision for people with MS, other than compensating a little bit like the yellow tinted glasses, those things are not going to be fixed with glasses. So myopia will be fixed essentially with glasses or contact lenses. Oh, the other interesting thing to do is to squint. I mentioned that. If you squint and it improves it a little bit, we have an ophthalmologic and neurological test we do. We have people look through a pinhole. Just trying to see something through a little tiny pinhole actually has lens-like characteristics. It will focus light a little bit better in the back of your eye. So that's another test we can use. If you have a pinhole, you can even do it yourself. Put a pinhole in a card and go look through it. Squinting, you're kind of doing the same thing. Pinhole through the card, does vision get clearer through the pinhole? More likely a refractive error. I don't know that you have to do that and call your neurologist, but if you get that smart, they're going to be really impressed.
Great, thank you. Next question is from a Cindy. If an MS patient has damage in the thalamus, would you ever recommend deep brain stimulation as a method of repair?
Cindy, no, I don't think so, not yet. I think we got a long way to go before we really understand that. That's a really challenging problem. You're cutting edge about 2-3 generations ahead of what we're talking about with BTK inhibitors here. So no, I don't think we can say that, or we certainly can't say that yet, but we do have hope, and hope for other things.
Okay, great, thank you.
Nicolette, thanks, good question.
Nicolette is asking, please explain anything we can do now to restore lost function.
Yeah, well, Nicolette, that one's tough too. I mentioned some of the research that's ongoing. Right now, we'll actually remyelinate, and right now, restoration are the tools that we have in the belt essentially allow us to prevent. Someday we will have treatments that will restore. Again, some of the things I mentioned, Dr. I believe Franklin, the researcher, was talking about metformin, vitamin D, some of these things, and I'm not recommending that people go out and go on those things, absolutely not right now. This is research. If you want to get involved, if you want to try these things, do it through a research trial, do it through a research study, rather than go out there and do something, and then we don't collect data and we don't know whether it works. We don't collect scientifically rigorous data to know if it works. So, but right now, I don't think we're that close to restoring lost neurological function. The things that we use are more recovery, but there are a few things. If we're talking about pure neurological function, we actually do see that going on an MS therapy, a disease-modifying therapy, does in some cases cause some neurological improvement. We've seen comparative studies with biological drugs that actually show improvement in both arms. In the comparator arm and in the study drug arm, we see improvements 30% or so in some of our biological drugs improvements in people's neurological disability. Now that's related to treating the inflammation of the disease. I think what you're asking about is long-term, is restoration of that slow development of disability, that progressive disease, and that's the one we're most challenged on with our research now. Tolobrutinib in primary progressive is being looked at. We have some hope of the BTK inhibitors, perhaps, that they will help. But we really are going to have to unlock some of the secrets of the signaling and messaging of what these stem cells are actually doing when we create and can grow new nerve cells. It's been the promise of stem cell therapy for quite some time that someday we might be able to regenerate lost or dead nerve cells. But I'm afraid we're a long way away from being able to do that practically for an individual. Now, with that said, there are things we can do to make you better. Physical therapy, regular exercise, diet, quitting smoking, right? Don't take crystal meth. We covered that one already, right? So treating the general medical wellness, we have seen an avalanche of data in the past 5 or more years of just a rising tide versus a sinking tide. If you have medical illness that you're not addressing, if you have obesity is different. It looks like obesity might actually causes the immune system to be more aggressive in attacking the brain or the spinal cord. So weight loss and exercise, we know other things that can be done. Essential fatty acid supplements, vitamin D, these things we're talking. These are things you should be doing now because we have data and proof that they're effective.
Thank you. We have like 6 more questions to go, and I'm going to ask because of time, and people have been here a long time, just to go a little bit shorter, okay?
It's hard for me, Stuart.
I know, I can tell. You're just like the others that I know in from Tennessee, okay? All right, just quickly, a couple of people, though, that wanted to let you know what a great job you did. Patricia writes, very good presentation, a lot of information that I need to think about. I'm going to have to listen to the presentation on the MS Views and News YouTube channel, but it was very good and very great conversation and presentation. Thank you, Patricia. All right, next, Tammy writes, and I guess this goes back to like when you were speaking about a comprehensive MS center. She wrote, you also can't get this type of care when you live in a very rural area. Sadly, my goal is to stay as independent as possible for as long as possible, but I feel like I'm doing it without any support. My neurologist is 5.5 hours away from me.
That's really tough. That's really difficult. I can't say there's a whole lot good about COVID-19. But one thing that it really challenged us to do is to figure out how to remotely access our patients. We have other challenges for telemedicine in rural communities. Broadband, that's one of our biggest problems is broadband access. I can tell you from having to do telemedicine visits during COVID times with people far away or not even far away, but sequestered for risk in an area where they don't have good technology or they don't have broadband access. So rural broadband access is probably one of the biggest things as that comes. I think we have issues, and this is where advocacy comes in, where the MS Society can help, where each and every one of you can help, because these telemedicine visits could actually go away. Insurance companies are going to actually turn the screws, and they won't right now. We're in this sort of gray area, but they're going to start decreasing reimbursements for these things. They're going to make it harder and harder for us to do this, like they do. They tend to do everything else for doctors and patients. I get it, but it's a problem. It's a challenge. The other issue in rural areas is having the support services. So I can see you in a telemedicine visit and say, gosh, you need physical therapy. But if you got to drive 3 hours to get to the nearest, physical therapist, so lots and lots of issues. We can't solve them with any one stroke or any one initiative. But that's where advocacy comes in, is rural, and again, programs like this, access in rural America to everything is limited. And I think there are some initiatives underway that are going to help, but we have to keep the ball rolling. So your legislators, the MS Society, get involved. Let them know. Advocate with your insurance company. If they're cutting off supply, let them know. Let them know at the highest level. Get on their Facebook page. Social media has an impact. Brief example. Oops, sorry, Stu, it's supposed to be slow. But a brief example. I tried to get a therapy for a patient, a disease-modifying therapy for a patient for 6 months one time, and we just exhausted every opportunity. She went on this insurance company's Facebook page, and I say trashed them, but all she really did was just lay out all the problems she'd had. 24 hours later, someone from the insurance company called her. A week later, she had her treatment that we couldn't get in 6 months. It works, okay? Join together, advocate. Rural America is in much greater need. People like you need and deserve more than what we can provide right now. So please advocate. It's a huge problem. Great question. Thank you. I wish we had better solutions for you, but stay tuned and hang in there.
Everybody should know that in total land coverage, 80% of the U.S. is rural. In total land coverage, okay? Not saying population, but yes, there's a lot of rural out there, and that's what we have to hit on. And going back to what the doctor was saying about, the good thing to come from COVID with the virtual learning is that's what it is. I mean, all the organizations put out things, but for you all to know, especially locally, MS Fusion News has every Monday, we have something to do with physical wellness, all right? It's moving Mondays for MS, and we have physical therapy twice a month and yoga once a month and Pilates once a month, and we'll be adding to that as well. But, that's something that we're being branded for. So, all right. I am going to get to the back of the room to get that question, but I want to finish up with what's online first. All right. So Renee is saying, can you talk about phase 2 PPMS, Atari study using donor T cells to target EBV in MS patients shortly? I know it's a big subject, but
that's easy, Renee.
Short.
No. And rather than give you I don't know details of that study enough to speak about it intelligently and without perhaps misstating. But let's see, how can I? Is there any way for me to reach out to her later and answer that question? Because
probably yes. You'll just have to remember to ask me, and I'll have to remember who asked.
Yeah, screen cap that.
I'm doing it right
so we
now,
can respond to her. So in this, I think what you have done is simply pointed out an area, the complexity of all of the research going on, and even someone like myself, I eat, sleep, live, dream, breathe MS, but keeping up on everything all the time. Now, this is I will say that Epstein-Barr and what we're learning from this is going to be hugely important. We just don't know how exactly, but this is a really key development. It's going to lead to new therapies. It's going to lead to other ways to impact the disease, vaccination to prevent perhaps in the family members of people with MS. There's a whole host of things that we will be able to do, hopefully coming out of some of this research.
Okay, thank you. This person just wrote in her email address, and I'm going to ask her to please contact me, send an email to me directly, because when I close this screen, I lose all of this, all right? Okay, thank you. All right, Michael is asking a question. I have read that DMTs are not as effective as we age since our immune system slows. Is that true? And at 67, should I discontinue my DMT?
Boy, that's going to be hard to answer briefly.
But he's not dead yet, so he shouldn't stop.
He shouldn't stop. That one's easy. So essentially, there is a pretty big gap in our understanding of. We've done a ton of research on when to start treatments. We've done very little rigorous research on when or should we stop them. So, and the research we have is somewhat contradictory. So, essentially. We don't know. Immunosenescence is the concept, the medical concept that you bring up. When we're young, our immune systems are very active. They're very, I'll just use the general term, inflammatory. Relapses, MRI changes, the lesions, T2 lesions, gadolinium-enhancing lesions, these are inflammatory aspects of the disease. As the immune system ages, we don't know if it's the disease aging, but probably the immune system. As the immune system ages, it just becomes a little less aggressive. It's less able to make inflammation. And other reasons that we also don't understand well is the disease may shift more from inflammatory to more degenerative, whether it's really degeneration or whether it's the inflammation at a low level that's slowly killing nerve cells. Or another hypothesis is mitochondria. These mitochondria are the power plants of all cells in our body, but especially nerve cells. And we know in people with advanced or long duration of MS, they don't have as many mitochondria in their nerve cells. There's another theory that nerve cells may just be slowly starving to death because of these years and years of inflammatory damage, and the nerve cell has to repair itself, and the power plants just wear out. So we don't know. That progressive part of the disease is really, really a challenge. So I think we have so much to learn, and so few ways to impact that aspect of the disease. That is my first. And actually, Stuart, I lost the first part of that question. Do you remember it? I went on the second part.
That was a long time ago
Aging,
already.
yeah. So aging. Speaking of aging, for both
Whether
of
or
us,
not to stop when you turn 67. That's the bottom line.
So
Asked and answered.
So we do not know. I can tell you what my personal approach is. I have a conversation with the individual about what could happen. Here's the rub. If your treatment is doing more than we think it is for slowing down that slow worsening, and we stop it, and you worsen, well, we can always put you back on, but you're not going to recover back to where you were before. And so for me, that kind of keeps me stuck. Now, this comes up. We have some research on point to this. People who discontinue treatment on their own. There was a study 7 or 8 years ago of these were all comers, not after a certain age, discontinuing therapy on their own. 60% of patients within a year were back on treatment because they had a relapse or their disease progressed in some way. So problem is this. It's clear that some people in their 60s or older may not get worse or get much worse faster if we discontinue their treatment, but some people do. And the problem is, I can't tell who that is ahead of time. So conversation I have with people is to say, all right, if you're willing to take this risk that you might worsen if we stop your treatment, then we'll do it, but let's do it smartly. Now, the smart way to do this, so I approach this discontinuation in the same way that I approach initiating a treatment. When I initiate a treatment, that first 5 years is the critical time. We know that if that treatment is effective over that first 5 years, people are likely to do great. 3 to 5 years, 5 years is the best. So in a similar way, when I discontinue a treatment, we stop the treatment, I do an MRI at that time, I do a baseline neurologic exam, and then I monitor that patient every 6 months with neurologic exams. I may only have been doing their MRIs and neurologic exams, MRIs every 2 or 3 years in someone older. Maybe some people, if they've been real stable, neurologic exams once a year if they've proven themselves stable for a long period. But in that situation, all bets are off. We want to capture any worsening as soon as possible. So if you do decline and we put you back on treatment, we have to, you haven't lost very much. So that's the best way I can answer that question until we have better data. But thank you. Very important question and an issue we have not yet clearly defined.
Thank you. Are there any people in the room that have a question other than this person back here? Wow, look at all these people. You're first.
I have several questions, but I will cut it down to 2. And they're related. You talked a lot about remyelinating. How long until you think something is available? And then second part of it is, how do you tell if a nerve is broken?
Like that last question, like in the transection, like the pictures.
How about
you
an
mean broken?
axon?
An axon, yeah. I'm not sure about that one. Let me just tackle that while it's up front here. So, how I tell the best way, brain biopsy. Raise your hand. Who wants one? Sign up sheet in the back, right? That would be the absolute, well, that was a joke. No, we're not. Brain biopsies might be done for MS sometimes when the lesion doesn't look like MS at all and they think it's a tumor. But in general, so the only way to really see a transected axon would be to take a snapshot of an active lesion. And one of my colleagues demonstrated this with an electron microscope. It's sort of a famous picture. He calls these spheroids. When the axon's cut, it balls up before it dies. And they're called spheroids, if you want to look into that more. But But outside of that, we're left with clinical means. So your axons, basically the number of axons you have, and if the axon dies, of course, the nerve cell does. So those slow dying off the nerve cells is probably what's causing that gradual worsening of disability in persons with MS. So often the way we tell nerve cells are being transected and dying, we may not even see that very well on an MRI. It's through people's function. Their gait slowly worsens over time. Their cognitive function, that's the one that scares me the most. Cognitive function, just can't measure it. So can't measure it well. So no, we don't have good ways to measure a transected axon short of directly looking at it, but indirectly we can. Unfortunately, by the time we see that people have transected a lot of axons and those nerve cells died, it's too late. We can't grow them back. So get on treatment, stay on treatment. If we see any whiff of disease activity, move to a stronger treatment has been my approach. First part of that question, I'm sorry, I lost that one altogether because I did the second one first. Oh, yeah. You know, anybody's guess. I was really hopeful when I saw some of the phase 2 work coming out on the clemistine. That's being studied using the optic nerve as a model. And clearly, we saw improvements in optic nerve function in real people, but it was just something we could measure. It didn't make any difference to their vision. So as far as remyelination therapies, and again, this drug is still kind of stuck in phase 2. Hopefully we get to phase 3 soon. But and then there are a few other treatments being considered for remyelination. But right now, I don't know when an actual treatment or drug is going to be available, but we do have evidence that vitamin D is probably the most readily accessible agent that we have data on that you actually take now. So as far as remyelination, we have vitamin D right now, and it has shown evidence, at least in animal models, of remyelination. So another reason to take vitamin D as well. But to answer your question, I do not know. I hope it's sooner. I would say where we are now with a phase 2, probably 5 years if everything goes well. Best guess.
Yeah. I got permission to ask one more question.
Uh-oh.
What is your opinion and your thoughts on medical marijuana?
I don't necessarily need to have an opinion on it, because I do, but I don't necessarily have an opinion on it because there's data on point. So we have not necessarily large, well-done studies like on some of our therapies, but we have really pretty robust data on using cannabinoids in treating the symptoms of MS. Now, there's probably more to this, but the symptoms that we know that are positively impacted by cannabinoids, and essentially the two, we have a medical program in Minnesota with CBD and THC in it. The only two ingredients, although I think they just started doing leaf products, so that's a little more complex. But in the distilled varieties, you'll get CBD and THC, and you can kind of vary those two elements. CBD seems to have a little bit greater impact on pain management, although potentiation, this is a pharmacological term, if you take both of them together, they work 3 times as well as if you take one or the other. So it's like potentiation would be like 3 plus 3 equals 6, but potentiation would be 3 times 3 equals 9, so you get even greater effect when you use 2 things together. So CBD and THC work better together. So if I have a patient with pain, we have data on this that shows CBD. I usually start with a 50-50 CBD to THC. CBD might make your fatigue a little worse, but it doesn't tend to have a whole lot of side effects for people. THC, yeah, you're gonna raid the fridge. You know what I'm talking? Anybody go to college? You know what I'm talking about? Yeah. You get the munchies or whatever. That's what makes you high. It's the THC. My patients don't want it to get high. They want it to help their spasticity, which is probably a little more THC effect on spasticity. High CBD, lower THC for pain management. Higher THC, lower CBD, or more like a 50-50 if we're treating spasticity or sometimes going up on spasticity. Then there's a lot of other things that we know about cannabinoids. How you take the cannabinoid is important. If you ingest it, if you swallow it, and it goes to the gut, it's processed in the liver, and it breaks down to a very slow acting, it takes longer to come on, lasts a lot longer. maybe too long if you take it at night and you're still a little goofy in the morning. So another way to take it is to absorb it through the lining of your mouth. So that's tinctures, oils, sprays can do that. And then that peaks maybe 30, 40 minutes. You'll start to see the effects, but it won't last as long. It'll last 3 or 4 hours and fade away. Then there's a vaporizer pen. So you can vaporize. We don't recommend smoking, although vape has its own issue on lungs. I have a lot of my patients who can't do the vape because it does bother the lungs, even the new distillates that don't have the vitamin E. All the lung problems we were hearing from the kids vaping seemed in part to be related to some vitamin E that made it smoke a lot more. But now the distillates don't have that issue, but they can still be irritating to the lungs. And of course, the last recommendation would be smoking it because you get other chemicals. Although it's kind of interesting, the more you heat it up, the more it breaks down into other different compounds and chemicals. So again, it's not so much opinion. We have data. We have science on this. This is approved. We have pharmaceutical products approved in numerous countries around the world. Canada has pharmaceutical THC, CBD-based pharmaceutical products. FDA approved. We have it approved for treating epilepsy here in this country, or a similar product. But at this point, we have data. It works. It may not stop everything. It may not treat everything, but adding it in addition to other treatments we're using for pain.
I have 2 questions. The Epstein-Barr, if you have ever had it and swear that you never have, can they draw a blood sample and see now, even after this many years, tell that you had it?
Yeah. So first question, yes, Epstein-Barr. So we can tell. Well, we don't actually measure the virus. What we do is we measure the antibodies against the virus that are in your blood. So a simple blood test can measure whether you've been exposed to Epstein-Barr. It's not going to help that much because when we look at population data, we see about 97.5% of people with MS have been exposed to Epstein-Barr, and people without MS, it's about 96% of people who have antibodies, so it's not a big distinguishing thing. Unfortunately, I'd love to tell you more about this, but the Stewart would get mad at me. So we have. I could talk another 20 minutes on Epstein-Barr alone. Sir, I think there's one more, and then, you have a second question. I'm sorry. Yes.
The vitamin D, is it possible to take too much?
Yes, toxicity from vitamin D, you have to be really careful about calcium. So when we check vitamin D levels, we also check calcium. High levels of calcium in your blood are much more toxic than high levels of vitamin D, but vitamin D causes your body to absorb calcium and actually use calcium much better in your body metabolically. But we do have to be careful. So we try to dose people consistently with a vitamin D level with a vitamin D dose for about 3 months. And then you can check a blood level. I check a vitamin D, D3 is the blood level we check, and a calcium level. So, and then once you kind of get a sense of where people are ranging, I find in Minnesota it doesn't really change that much winter to summer, maybe only 10 points or so, and people are taking similar doses. But yes, we want the vitamin D levels toward the upper range of normal if we can get there. Now, one caveat, I mentioned this before, if you have a history of kidney stones or a family history of kidney stones, you need to be cautious. Vitamin D will increase the chance you're going to develop kidney stones. So that's something to be aware of. Okay. Good questions, thank you. And we'll get to you next after this one. Thank you.
Well, you pretty much talked about this, but I'm 82 and my mom was 106. And I just wondered do you think I should be off medication? I have been off for about 7 years. And I'm beginning to think that I should probably be on if I was taking a shot, but maybe it would be easier to take a pill.
Yeah. So I can't really give you individual medical advice. I mean, even if you were my patient, I'd still need your chart, and it's those sorts of decisions are really complex. So it's a conversation you need to have with your neurologist. In general, I can, in broad strokes, say that we look at a lot of factors when we're deciding what treatment you're on. If we're thinking about discontinuing a treatment, you're talking about restarting one after it's discontinued. As I said earlier, my approach is to monitor people really carefully and see how quickly they're changing. Often I will have a track record of years with someone on a treatment, and when we stop it, we can see, is their gait changing, or their MRIs changing faster than they were before when they were on a treatment. But that's why I have to kind of monitor someone for 4 or 5 years. This acceleration of the worsening may happen very subtly, so it's sometimes really difficult. So
It wouldn't be on the initial charts, it would be on the latest charts.
I'm not sure I understood what you meant by that. It wouldn't be on the...
I used to go to the Golden Valley Clinic, Birnbaum Clinic,
Uh-huh.
and that's why I was wondering if it'd be on the old clinic or if it'd be on your records.
Yeah, I can tell you actually, because I was just looking through some of Dr. Birnbaum's old notes, that they are all still there, or at least most of them. But this is very important. If you have old medical records, they might be useful, especially in a situation like this. Your doctor only has to keep them for 7 years. So you want to get your hands on your MRIs, the images of your MRIs. Sometimes I want to look at an MRI from 10 years ago on somebody, and they may not have them. So if you have your MRIs, the ones on films, hang on to those. They're valuable. Don't get them wet, okay? That's the only thing that messes up. Keep them, toss them in your closet, someplace dry. Don't get them wet. But otherwise, get your MRIs on a disc or a CD. Get any of the medical records. At 7 years, they drop off, and it might be useful in making a decision about your treatment. So, best I could tell you would be to follow up and kind of see what's changed. Dr. Birnbaum did collect things like timed walks. He did fairly careful neurologic exam. He's not dead. He's just not practicing anymore. So,
Okay. Next question, please. Sir,
Okay, I have a question. Several years ago, I woke up one morning, and my right eye, it's like you put a slip of paper across the top half was black, bottom half was normal. Was that an MS symptom?
did it go away?
It blended.
Didn't understand?
It blended.
The
Still don't know what you mean by
top,
that.
The top black and the normal just blended. So
Still not hearing too well. So you said you lost the top half of your vision in one eye?
right eye,
Okay,
so
so
black. The bottom half was normal.
the top
then
was black,
after-
the bottom. Okay, so I can't advise you as a patient, so I can speak in general terms about some of the things about optic neuritis and what optic neuritis typically does. The classic problem with optic neuritis is people lose vision right in the center. Realistically, that only happens 10% of the time, okay? We see all sorts of other ways that the vision, when someone has optic neuritis, can change. Optic neuritis almost always has pain. 90% of the time there's pain. Maybe it's just when you move your eye from side to side. And optic neuritis usually is going to improve or improve a lot. If people have had multiple injuries to the same optic nerve, maybe not so much. However, when you describe a stark demarcation across the horizontal meridian where the upper half is gone and the lower half is good, that sounds more like something we call an ischemic optic neuropathy. An ischemic optic neuropathy is a blood flow problem to the optic nerve. There are certain risk factors, but it can happen to anyone. It happens as we get a little older, if we have diabetes or hypertension. But the other characteristic of ischemic optic neuropathy is it doesn't improve very much at all. So optic neuritis improves a lot. So if anyone has optic neuritis, they're more than likely going to experience a substantial improvement. If you have something like an ischemic optic neuropathy, it's not going to improve very much. Thank you.
Thank you.
Okay, still on the subject for optic neuritis, you talked about the glasses being amber and yellow. Is there anything for like a so-called a flare, where you don't have pain but your vision's, say if you're overtired, if there's anything you could take like a leave or anything that could?
Are you describing a flare when you say a flare, like a flare of your MS or
yeah, to the optic nerve,
Yeah.
like.
So this doesn't have so much to do with the optic nerve. It has to do with a demyelinated nerve, period, regardless of where it is in your body. So if you've had damage in your spinal cord, and let's say you had a relapse that caused a right tingly, numb leg, that over a few months kind of mostly went away, but then it tingled every now and then if you got tired, fatigued, overheated or something. And then let's say, I wish COVID on you, let's find something else, a flu or something else, you get sick and your body temperature goes up. Your leg will start tingling again, almost as bad as it was the first time. But when your body temperature comes down, when you recover from the illness, it will gradually go back to the way it was before. So that would be called a pseudo relapse or pseudo exacerbation, an old problem made worse by something that sinks your whole boat, an infection, stress, sleep deprivation, lots of things can kind of sink the whole boat. In a similar way, the optic nerve is just like, demyelinated optic nerve is just like demyelination in the spinal cord. If you're tired, stressed, overheated, fatigued, your vision in a damaged optic nerve, a demyelinated optic nerve, even when it's fully recovered, may temporarily worsen. So that's kind of the key. If you have an illness, if there's some environmental factor that's sort of triggered something that sunk your whole boat, and your old optic nerve problem is a little bit worse, even a lot worse, but only temporarily, you wouldn't experience more pain or pain with eye movement again. It's just the vision would be dimmer. Then more than likely that is a pseudo exacerbation of your old optic neuritis rather than a new one.
Thank you. Very
Welcome.
last question, because otherwise it could be here all night,
Well, I got the time.
You answered about 80% of this question a few minutes ago. Regarding vitamin D, I was taking 3,000 international units, one tablet, a 3,000 IU tablet, and I ended up with vitamin D toxicity. And
Wow.
So they took me off of it totally.
How high was your level? I'm just curious. Do you remember what the number was?
I'm sorry, I honestly don't.
Yeah,
I don't remember where the numbers were at.
Yeah. And what were your symptoms?
And now I'm just kind of wondering, when you go to the store to buy vitamin D, there's, 10 different jars, ranging from, all kinds of different international units. Is there kind of just a general guideline? I'd like to get back on it. I just wondering what.
Again, I can't give you specific recommendations for you. If you were my patient, having had vitamin D toxicity at that dose is, especially for some, I assume you're here because you have MS, and if you have MS, we know that MS or the vitamin D deficiency is probably more of a bystander effect with whatever the genetic predisposition to MS is. In other words, that gene gets damaged when one of the genes that may be important in MS gets messed up. So most people with MS, we're in the 90+%, have very low vitamin D levels, and there are defects in vitamin D metabolism in that situation, so that we have to give people with MS generally huge doses just to get them to the lower limits of normal, or if we even mid-range. And if we're targeting the upper range of normal, it's not uncommon. I have some people I'm treating with 15,000 units a day just to get them to a 60 when our target is 80. So if I had a patient who had your situation, my response would be to get a specialist involved to say, look, if we had this response to that low a dose of vitamin D, I mean, I live in Minnesota, 2,000 to 3,000 units a day is not an uncommon dose for everyone to take, and they don't get toxic. So if someone develops toxicity on a relatively low dose, that might require specialist evaluation, because there are some other disorders, endocrine disorders, that can affect people's metabolism of vitamin D, and that would be something that if you were my patient, I would have you see a specialist for an opinion about that.
Thank you, doctor. It was a nice long day. There's a lot of questions, a long talk. I'm hoping that everybody got something out of this. Anyway, again, doctor, thank you for all this. I can't wait to do the next one. Okay, so I just want to thank you all, and we're going to say good day, have a great one, drive carefully. Bye-bye.